Folks, we'll get started in about 1 minute. Give people time to log in. I am going to begin. Good afternoon from the East Coast and good morning for those in the West Coast. My name is Joe Ricalto, Policy Director for the NMAC, and I am welcoming everybody to, I believe it's going to be our second Medicaid town hall, but fourth town hall for NMAC. And just as a note, we are going to be scheduling another town hall within the next couple of weeks to go over the appropriations riders, as they will affect, no doubt, many organizations and folks here joining us today. We wanted to schedule this follow-up Medicaid town hall after the big, beautiful bill, HR 1, passed out of the House last week. And I'm really honored again to have Rachel Klein, Deputy Executive Director from the AIDS Institute, join us again. And Matt Salo. Matt, for those that don't know Matt, he is currently he was the founder and he's the current CEO of Salo Health Strategies. Matt, it's good to see you. But for the purpose here, he was the former executive director of the National Association of Medicaid Directors. And we thought it would be good to have Matt and Rachel join us today to kind of unpack what the House did last week and get into a little more details with some things that we know are certain. As you recall, our last town hall, we were going off a version of the HR 1, which had been, modified, obviously, to get the votes. And now that we know it passed the House, we wanted to kind of have this town hall and level set as we move forward into the Senate. So with that said, I'm going to turn it over to Matt. Matt, thanks for joining us. We are very, very grateful here. If you could give us a complete kind of overhaul, the big picture of what this bill does and does not do, and particularly if you could talk a little bit about hospitals, and especially rural hospitals, which we believe this bill will be catastrophic. So Matt, I'm going to come off camera, but I'll be monitoring and certainly we'll popcorn things back and forth. Okay.
Okay.
So Matt,
you'll be keeping an eye on me. Okay.
I got you, Matt. Take as long as you want, my friend.
All right. Thanks, Joe. And hey, everybody. So I think the first thing that I would want to do when putting all of this into context is kind of step back from the process itself, because as we all know, there's one big beautiful bill that has passed the House, and the process then goes to the Senate. I don't think the Senate is going to approve what the House has done. I don't think anyone thinks that. So we've got a whole lot of conversations that need to happen about what's going to end up in the final package. But before we spend a lot of time in there, I did want to kind of like step back a little bit and talk about some of the other context from the state kind of government and budgetary perspective. I spent 30 years of my career working for or on behalf of state government agencies, either state Medicaid directors or governors. And so a lot of this is kind of in my DNA. And before we even start to talk about what's in that bill or what the implementation dates are or what the policies are, I think it's important to note that, number one, 45 of the 50 states entered fiscal year 2025 with a structural budget deficit. And that is important because obviously the state governments have to balance their budgets every single year. Unlike our friends over here on the Hill who can pretend to do so or get a pass for not doing so, every state has to balance their budget every year or on a biennium basis. And we are coming out of a period of time post-pandemic where all of the significant congressional interventions and investments in Medicaid and other state government resources have run out. And that is leaving big holes everywhere within state budgets, and states are struggling right now to kind of to grapple with those and to come into compliance. And many of you may have seen the budget, the preliminary budget that Governor Newsom in California just released within the last week or so. Significant cuts across the board everywhere in the state, and especially within Medicaid. And that's the kind of thing that you are going to see and continue to see in the vast majority of states across the country over the next year plus. So that's happening right now. Number two is that states are also kind of looking at the nature of the overall economy, and is the overall economy doing well, or is it challenged? Are we seeing tariffs or the confusion and chaos caused by tariffs impact port activity, impact supply chains? And it's a little too early to say definitively what the answer on that's going to be, but I think in the big picture, it's not looking real good. So that's hit number 1 and 2 in terms of what's happening right now. And it's within that context that Congress is now looking to extract, $600, $700, $800 billion additional out of the Medicaid program over the next 10 years. And that's what I think has states the most concerned at this point. And we'll talk a lot more about what those actual provisions are, what the impact is going to be, but it's hitting states when they're down. It's extracting money, or extracting federal dollars out of the system at a time, quite frankly, where few, if any, states will be able to absorb much or all of that hit. And one of the things that I have heard consistently from a lot of folks is, looking at the Congressional Budget Office estimates of what the various impacts will be in terms of federal costs, in terms of the number of uninsured that it will create. As CBO looks at the various proposals, baked into a lot of their assumptions are that states will be able to backfill a significant, not all, but a significant portion of those funding reductions in order to minimize the shock to the system on healthcare. And quite frankly, I think that is fanciful at best, and I don't want to call it disingenuous because I don't think CBO would do that. I just think it's plain wrong. That the states are simply not going to be in a position to backfill any amount of money, any amount of significant money with these cuts. So when we look at the proposals that are at least in the House bill, and again, I think what the Senate does is going to be very different. And there's some very interesting dynamics playing out with Senator Josh Hawley all of a sudden becoming my wife was like texting me, was like, oh my God, is Josh Hawley now a Medicaid guy? And I had to say, look, no, he doesn't. He's not a huge defender of Medicaid policy, but he's a pretty astute student of geopolitics. And I think the thing that's really important here as the House bill moves into the Senate and moves forward is that the political dynamics around Medicaid and Medicaid cuts and what has happened in the last 8 years since repeal and replace are that two really important things have happened, and I think these things are really important to pay attention to. One of which is Medicaid hit almost a high watermark of almost 100 million Americans covered at the height of the pandemic. And for a program that has really suffered a long time for being too complicated, too confusing, too balkanized for people to really understand, I think we kind of hit an inflection point of people saying, oh, wait a minute, Medicaid's not just some program for low income people, those people over there. I'm on Medicaid, my kids, my brother, my mom, whatever. The recognition of what Medicaid is and does for people grew and increased in ways that I think we wished we had 8 years ago. The other thing that's really important is that with the political realignment in this country, President Trump won a majority of low income voters. So the Venn diagram of his base and people who were on Medicaid and did not vote for him to cut it have overlapped in a really significant way. And I think that's the kind of thing that people like Senator Josh Hawley are looking at and saying, wait a minute, if we get pegged as being the party that is undermining Medicaid for our base, we're in real trouble, long-term politically. And that's why you see so much of the narrative around the House bill and the conversations in the Senate all kind of like trying to find purchase, trying to find well, how do we take $880 billion out of the system and not actually hurt anybody who benefits from it? And the narrative kind of comes into, oh, waste, fraud, and abuse. As long as we're clearing that out, then we're safe, right? And to a certain extent, I think a lot of that really sunk in. And that's why some of the really, really bad things that were in the original House proposal, like, block grants and per capita caps, like big changes to the federal matching rate in a lot of states, elimination or reduction of provider taxes, that's not in there. It's been replaced with a lot of nickel and diming, and by nickels and dimes, I mean $5 and $10 billion here and there, of like eligibility policy of freezes in how hospitals can get money. It will have an impact, but I think strategically what they're trying to say is, don't look at this. This isn't going to hurt people. I think that's not true because if you look at the work requirement piece that's in there, if you look at the eligibility policy changes, if you look at the changes in retroactive eligibility from 3 months to 1 month, if you look at the immigration policy changes, if you look at the freezes in provider taxes and state directed payments, it's going to mean, and you look at the CBO scores, almost all that money is coming from the assumption that people are losing Medicaid coverage. And in a lot of cases, it's not going to get replaced with anything else. And when you've got, 6, 7, 8, 9, 10, whatever million Americans losing Medicaid coverage for whatever reason, that is going to have a real significant downstream, immediate impact for the families and immediate and downstream impacts for hospitals who are going to have to increase their uncompensated care loads with even less money to do so. It's going to impact the MCOs who, do not want to see this kind of churn that comes from people coming on and getting off and coming back on to coverage. And it's going to have a really significant impact. And quite frankly, the reaction that you're going to see, and I'll stop here and I'll turn to Rachel and would love to kind of answer whatever questions I can at the end. But, the real thing to think about is that as the impacts of these various changes start to hit states, whatever the date of that is, the reaction that states will have is, quite frankly, they go through this decision tree of what do we do when there's a budget crisis, and it's a whole bunch of really like suboptimal choices. But the practical thing I think you're going to see in almost every state in the country is, it's not going to be, hey, here's an optional benefit or here's an optional, eligibility group we're going to get rid of. And quite frankly, it's not going to be raising taxes. In reality, what it's going to be is states just pushing all of that damage downstream. So rather than, just like the federal government Congress doesn't want to be on the hook for saying, we did this thing that made people lose coverage. States are going to say, we don't want to be on the hook for making those decisions either. So they're just going to reduce everybody's reimbursement rates. So reimbursement rates to, capitation rates to the MCOs, payment rates to the hospitals, payment rates to everybody under the sun are just going to get squeezed down and down and down and down to a point where, some number of those just give up on serving Medicaid altogether, and others restrict the number of Medicaid patients they can see. And again, that is going to impact every population, and it's going to impact non-Medicaid populations as well. And that's I think the real damage and the real challenge out there. So that was a lot. I'll stop there. Happy to turn to Rachel or however you want to work it, Joe.
Matt, thanks for that. And I've got a ton of questions. I just wanted to say for the folks attending, if you have a question for Matt, Rachel, or myself, you can go ahead and put it in the chat, and we will, Zach will be monitoring those questions. Before we go to Rachel, can I just throw out there three things that have come to my mind, Matt, as you were explaining so nicely? Rural hospitals. The effect on rural hospitals, I mean, we have heard it's catastrophic. If the House plan goes into effect, it will be catastrophic for rural hospitals, which unfortunately for people living with HIV, a lot of folks, are in the rural areas of this country. Any thoughts on rural hospital impact?
Yeah, no, I think, the safety net hospitals, the rural hospitals, critical access hospitals are already, so much of their patient load and revenue streams are from Medicaid to begin with. So any impact on them is going to be doubly and triply felt, whether that's losing eligibility for the people they're serving, whether that's the chilling effect of some of the immigration policies and public charge, or whether it's the freezing of the provider tax rates or the state directed payments that, quite frankly, they are increasingly relying on to keep their doors open. So every hospital will get hurt. Rich hospitals probably have a little bit more socked away to kind of keep their doors open a little bit longer, but the rural hospitals are going to be the first ones to get into real crisis.
And one more question, and thanks for that. I do want to talk about the public charge as well. But I've heard, Matt and Rachel, that it penalizes expansion through ACA. So through ACA, states had expanded. How would you respond to that? That it penalizes those states that expanded the Affordable Care Act?
Well, I think one of the main things, and I'd love to turn to Rachel for her thoughts on this as well, is as you hear the crafters of the bill talk about what they're doing and why they're doing it, you hear this message of, hey, we want to return Medicaid to its original purpose. With the original purpose in their minds, I guess, being pregnant women, kids, and frail seniors and people with disabilities. And in fact, you were seeing, some of them, actually saying, look, if we can just get those 26-year-olds out of their parents' basement and playing video games and then out. Sorry, I've got the Washington Post calling me. I got to hang up on them. Get them out of their parents' basement and playing video games and getting them a job, then Medicaid will be fixed. Well, that's the Medicaid expansion. So it's clear that's what they're going after. They don't really want to come right out and say it, but that's what they're going after. And then, things like the work requirements provision, which, I think you can design a work requirement or a community engagement policy that is effective and that invests in people and that tries to focus on increasing educational opportunities. But if you try to, if the intentionality of it is to, go after those lazy 28-year-olds or whatever, and if you try to roll it out in 18 months from now, it's going to be a paperwork requirement and not a work requirement, and you're just going to see a lot of people losing coverage when they didn't have to.
Thanks, Matt. Rachel, the floor is yours. What did the House pass? The overview, now that we know.
So the House bill that ended up passing was a lot like the bill that we talked about a couple weeks ago, with all of those proposals in it that were really going to be very harmful, right? Like you talked about the work requirements, the increased cost sharing for people who are in the Medicaid expansion, making a lot more paperwork, making it harder for people to get onto Medicaid, to keep Medicaid, and the ACA, by the way. We should acknowledge that a lot of what this bill ended up doing included making it harder for people to get coverage in the market making it harder for and making it more expensive for that coverage that people are purchasing in the marketplace. So all in all, we saw exactly what we thought we were going to see, plus a little bit more, because they needed to appease some of those hard line I want to say deficit hawks, but it's hard to say that in a bill that's going to end up increasing the deficit by, trillions of dollars. Folks who wanted to see this bill worse got some of what they were looking for. So some of the things that, like the work requirement, was supposed to start in, I think, 2029, and now it's going to start at the end of 2026. So they moved some of that stuff up. They made a couple of other things worse. We saw in the original version of the bill that they were going to remove gender affirming care for minors, and that care is now removed in Medicaid for everybody. So some of those things got a little bit worse. Lots of provisions that will affect coverage for immigrants, both in Medicaid and in the private market, and in Medicare. And I think we have to, that's actually one of the things that I'm not sure we did talk about in our last call, because it was before this information came out. But, CBO, the Congressional Budget Office that provides the analysis of what these bills are going to do, said that this bill is going to increase the deficit to such a degree that it's going to trigger an already existing bill that will require cuts to Medicare of something on the order of $500 billion. So in addition to some other cuts to immigrant coverage that this bill includes in Medicare. So, I think it's important what Matt was saying about none of this taking place in a vacuum. None of this is taking place in a vacuum, and not even within sort of the healthcare sphere. The bill also includes really significant cuts to SNAP, to nutrition services, cuts to, I think they're already talking about LIHEAP cuts that will, cut funding for low-income people who rely on heating and cooling benefits that they get. There are a raft of provisions that are going to be incredibly detrimental to low-income people, to people with chronic illness who are relying on Medicaid and or on marketplace coverage, because it's going to be so much harder to get those programs, to keep those programs, and because people who are still getting Medicaid coverage, like Matt said, are going to have a much harder time finding a provider. And they may be looking at benefits that are going to get cut as well as a result of all of this removal of federal funds. So there's nothing in any of these in this bill that is going to improve healthcare. There's nothing that's going to provide more job opportunities. In fact, and we were talking about rural hospitals, in a lot of communities, and particularly rural communities, those hospitals are the biggest employer in the community. So when they either face closure because they can't keep their doors open, or when they have, reduced funding that they're getting because of this bill, they're going to be laying off a lot of workers. So this is not a bill that is going to increase connection to employment or increase the number of people who are going to have jobs. And it's not going to do anything to, remove the need for getting care. So what we're really going to see at the end of this is a lot of people who are sick or going to be sick and are unable to get the care that they need.
Rachel, thanks for that. Matt, and I know we're running on time here. You did reference public charge, and I had some questions regarding the public charge, but I'm wondering, before I ask that, if you could explain to everybody what the public charge is.
So basically, I mean, there are provisions in here that are going to penalize states for covering individuals, for covering immigrants. And, immigration policy is very complicated. It's basically, it's a federal policy decision, which we always used to say at the Governors Association. And, for the most part, undocumented citizens don't get Medicaid. With some exceptions, for emergency use in certain hospitals. And legal immigrants, there's supposed to be a certain period of time they're supposed to be in the country before they access public benefits. Part of the concern that is raised is that there are states out there like California, New York, DC, and a bunch of others that are providing a Medicaid-like benefit to immigrants with state-only dollars. And what it would actually do is reduce their federal match in Medicaid for doing something with 100% state dollars, which I'm not a lawyer, but that sounds like that's on questionable constitutional basis. There are other concerns being raised that some states are not doing as much as they could to ensure that someone that their immigration status is 100% accurate before enrolling them. And again, increased penalties for states to do that. And I think, the sum total, and there's more in there, the sum total of all of that is going to, and especially given kind of the zeitgeist in this country these days on ICE and immigration, I think you're going to see a chilling effect on individuals who are coming forward to get care, and kind of pushing a lot of their care out into the alleys and the shadows where tuberculosis could run rampant, or impacts directly on the hospitals and the states, getting penalized for doing what they need to do. I don't know, Rachel, if you would say more about that.
No, I mean, I think you've covered it, is that, people will be afraid to apply for Medicaid. They'll be afraid to go get care at the hospital. They'll be afraid in general, because they don't want any of their information to be shared with ICE, especially if they're in a family that has some undocumented members. And we think have to be really clear that that there are lots of mixed status families in this country where they may have children who are citizens, some family members who are lawfully present, and some family members who are undocumented. And that is, that's just the way that this country works. And so, a lot of the policies that get put into place that are designed to reduce access to care for immigrants end up hurting both people who are undocumented as well as people who are lawfully present or legally residents, and any U.S. citizens who are in those families as well. Quite often, those are children. We also know that all of the cuts that are going to be made that are going to affect adults are going to have a huge impact on kids, because when parents can't get coverage, their kids end up not getting coverage. And we have lots of data to show that that's true. Before we completely run out of time, I want to just mention that, this is not over by any stretch of the imagination. This is just the House passed bill. And Matt talked a little bit about how the Senate's now going to go through its process. And, the Senate may take elements of what's in the House bill, and they may have other things that they're going to do. We are expecting the Senate to be including a Medicaid work reporting requirement in its bill. The Republicans, by and large, seem like they are totally in favor of that, because it is something that they feel like they can stand behind to say this is cutting waste, fraud, and abuse, even though we know that that is not the case. And we are starting to hear a lot of rhetoric coming out of Senate offices, as well as the House offices, saying there's nothing in this bill that is going to cut coverage for people. And I think some of folks really genuinely believe that. And I think what our job is to show them that that's not true, is to show them who are the faces of their constituents, who are the people who are their constituents who are going to suffer, and to be very vocal about that and very loud in a number of ways. We want to make sure that they're getting calls to their offices in DC. We want them to be getting calls to their district offices back at home. We want them to be getting visits, emails at all of these locations, and to be hearing the real stories about people and what this is going to do to their access to care. Letters to the editor are, in home papers are really powerful because those are constituents saying what they think directly, and getting published, in their local communities. And that's something that members of Congress and senators pay attention to. So, we have a window now between now and about, July 4th, which is when the Senate wants to get their bill done. And that's the window that we have to influence what goes into that Senate bill. So, we want to make sure that everybody is doing everything that they can to reach out to senators and to tell them what harm this is going to cause. We have lots of resources that, we can send out to people that will help give you information about, what to say in those letters to the editor and in those calls and emails. And I think we just want to make sure that it's not something you do once. This is something you do over and over again. It's not like voting. So, get the word out, tell your coworkers, your family members, your neighbors, your friends, and let's make sure that they hear from our community about what's at stake.
Thanks, Rachel. My internet is unstable, so if I freeze, you can finish up for me. But Matt, Rachel, I do want to thank you very much. This has been very informative. We will definitely keep in touch. And to everybody, if you want more information, you can email policy@nmac.org. And we will, to Rachel's point, get you information on how to go and target the Senate, particularly 9 senators. So, but thank you, everybody. Matt, Rachel, thank you so much. And we hope you all enjoyed and found this town hall informative. We will send out information on the next town hall. Matt, thank you. Rachel, good seeing you.
Thanks so much.
Thank you.